The next section of our program is really focused on electrophysiologic issues that are relevant for board study. And I'm pleased to introduce Dr. Sunil Kapoor, who will speak to you about atrial fibrillation and common supraventricular tachycardias, to be followed by Dr. Tedrow, who will speak about bradycardias, syncope, and sudden deaths. Dr. Sunil Kapoor is an instructor in medicine at Harvard Medical School and a key member of the electrophysiology section in the cardiovascular division at Brigham and Women's Hospital. So, Sunny, take it away.
Great, thank you. So like Dr. Desai mentioned, we're going to be talking about atrial fibrillation and other common supraventricular tachycardias. So to dive in, as we all know, the cardiac conduction system is relatively consistent between patients and relatively complex. We start with the electrical impulse at the sinoatrial node. It then moves down through intranodal fibers to the atrioventricular node, and then down through the His-Purkinje system, where the electrical signal results in ventricular contraction and a heartbeat. Because it is complex, there are many areas throughout the conduction system that can be, for some reason or other, damaged or result in an abnormality that gives us an abnormal heart rhythm or an arrhythmia. We can obviously define those or subdivide those in a lot of different ways: bradyarrhythmias, tachyarrhythmias. But the nomenclature that sometimes we use to try and really make it a little bit more manageable is where we think the arrhythmia is coming from. Arrhythmias that start at or above the atrioventricular node are considered supraventricular, and those below the AV node are considered ventricular. What we're going to be talking about today is tachycardias at or above the atrioventricular node, which we all commonly refer to as SVTs or supraventricular tachycardias. Now, if you think about it, the most common SVT is actually atrial fibrillation, something that we clinically deal with all the time. We oftentimes keep it separate from the term SVT because it is so big and such a major clinical issue. But pathophysiologically, it really is just an irregular supraventricular tachycardia. We'll spend most of our time talking about the basics of atrial fibrillation and then talk about one of its brothers or cousins, atrial flutter. We'll spend a little time at the end talking about some of the what we classically call SVTs, but are probably better described as regular paroxysmal supraventricular tachycardias, including the three major mechanisms or the three major ones that we see. So to start with atrial fibrillation basics, as we all know, atrial fibrillation is by far the most common clinical arrhythmia that we have to deal with. What happens in atrial fibrillation is that the normal electrical impulses of the atria are overwhelmed by disorganized electrical impulses. What happens is that we then get the very classic EKG pattern where the normal P wave, the normal atrial electrical signal, is lost, and on the top EKG, you see in atrial fibrillation that the P wave is replaced by a continuous disorganized fibrillatory wave throughout the tracing. This also results in irregular activation of the ventricle, as seen here by the irregular QRS complexes, which of course then results in an irregular pulse that one might feel on a physical exam, and the sensation of irregular heartbeat or palpitations that patients might feel. The reason that we're going to spend so much time on atrial fibrillation, and the reason that many of us in clinical practice spend so much time on it, is because it is incredibly common. The estimated prevalence is upward of 3%, and it very much is a disease of aging. I often give the analogy to patients that it's somewhat like arthritis of the heart. Just like the knees, just like the eyes, as we get older, atrial fibrillation becomes much more common. The incidence approximately doubles with each decade of life after the age of 55. If you look here at a Medicare population, as we go from our late 60s to our 90s, there's almost a linear increase in how much atrial fibrillation prevalence we expect. Now, the biggest problem with atrial fibrillation is not only that it's common, but it's also expected to grow dramatically over the coming decades. If you look at in the blue dots here, the estimated current prevalence of atrial fibrillation, and this is 2010 data, in the US, we have around 3 million AF patients. But if you then look in the orange circles at what the 2050, so 30 years from now, estimated prevalence might be, we see a dramatic increase, upwards of around 8 million. And this is not only true in the United States, but throughout the world, in Europe, Africa, India, China, and so on and so forth. I used to title this slide that AF is a global pandemic. Of course, we reserve those terms for other things now, but certainly one of the major concerns with atrial fibrillation is that it worldwide is growing very rapidly. So why is AF growing so rapidly? We used to think atrial fibrillation was something we would call lone atrial fibrillation, that it just happened to patients and they had no other disease, it's just the atrial fibrillation by itself. We now understand that most likely the vast majority of patients have atrial fibrillation secondary to some other risk factor. There are non-modifiable risk factors like age that we touched upon, gender, men are much more common to have it than women, genetics, so on and so forth. But there's also a lot of modifiable risk factors. If you look through the list, it becomes a little bit more apparent why the prevalence is growing. We have an aging population, especially in Europe, which is predicted to have a lot more atrial fibrillation in the coming years. And a lot of the risk factors like hypertension, obesity, diabetes are increasing throughout the population. This also gives us some clinical insight. We know that the global population is increasing because of these risk factors, but if we see a patient in front of us with atrial fibrillation, one of the clinical steps that we oftentimes think is, of these risk factors, what is leading to this patient's atrial fibrillation? So when I see a new atrial fibrillation patient, I often go through how can we rule out or modify these things? A thyroid panel to make sure thyroid disease isn't causing it, an echocardiogram to make sure valvular heart disease isn't causing it, and so on and so forth. Now, the other complexity associated with atrial fibrillation and diagnostics is that it just doesn't come and sit there. But oftentimes, for many people early in the disease, atrial fibrillation can come and go. As we all know, paroxysmal atrial fibrillation is the terminology used when atrial fibrillation terminates within 7 days of onsets. These episodes come and go oftentimes on their own. For nomenclature purposes, we call persistent atrial fibrillation when an AF episode will last 7 days or longer, and then longstanding persistent as an episode that lasts greater than 12 months. Permanent atrial fibrillation is related to persistent or longstanding persistent atrial fibrillation, but is really more of an agreement among the patient and the clinician to no longer try and restore sinus rhythm. Permanent atrial fibrillation means we are willing to permit atrial fibrillation permanently as compared to, for example, longstanding persistent atrial fibrillation. This is important because clinically, when we go to diagnose atrial fibrillation, one 10-second EKG might not be sufficient to capture perhaps a paroxysmal atrial fibrillation patient's episode. This is getting increasingly complex as all the wearable technology, the watches, the smartphones, and so on and so forth are becoming far more prevalent to the lay public and are oftentimes bringing us this information that we're trying to deal with in terms of how it actually is diagnosing the disease. Now, if you were to say there's so much atrial fibrillation, what is actually causing it? What is going on in the heart that causes atrial fibrillation? The short answer is we honestly still are not completely sure, but there most likely is a heterogeneous etiology of different atrial fibrillation in different patients. We used to think many patients with atrial fibrillation had what we would call multiple circuits. So these reentrant circuits that would occur within the heart and actually oftentimes pivot or circle around some little scar or substrate in the atrium. If there's one big circuit throughout the heart, we call that atrial flutter, and we'll talk about that more later. But if there's multiple small circuits, these could apparently collide or cancel each other out and give the appearance of atrial fibrillation. And this is probably true for some patients. Another very common mechanism of atrial fibrillation that we think is important for some patients is what we would call a focal driver. So there's just one part of the atrium that just decides to fire and fire rapidly. That allows for degeneration of the conduction through the atrium into what we would call fibrillatory conduction, giving the appearance of atrial fibrillation. Again, this is probably true for some patients, and some patients probably have an amalgamation between both multiple circuits and focal drivers. There's also this concept over the last 10, 15 years of what one would call a rotor, which is a little bit harder to kind of mentally get our heads around, but is essentially kind of like a hurricane going through the ocean, where it is a focus but causing atrial fibrillation in different time and space. Each of these probably has a different relative importance in different patients and is treated a little bit different in terms of trying to control the arrhythmia itself. Now, if you try to go a step further and say, well, what is the molecular cause of atrial fibrillation? Can we understand what protein malformation, what genetic cause is causing it in order to come up with the targeted therapy? We get ourselves into a bit of a mess. Because it is so common, because it is so heterogeneous, innumerable amount of mechanisms at a molecular level have been implicated in AF pathogenesis, which is to say that we don't have a specific pathway that we can target that would revert atrial fibrillation for most patients. In general, it is very heterogeneous and has added complexity because oftentimes it's very difficult for us to even tease out what molecular signals are causing atrial fibrillation and what are a byproduct or a downstream consequence of atrial fibrillation. I oftentimes use this to describe how it's probably a little bit away before we come up with the magic pill for atrial fibrillation, just because there's so much going on in terms of atrial, electrical, and structural remodeling that allows the arrhythmia. So a lot of talk about the mechanism, but how is this clinically important? Well, one of the things that we think about in terms of atrial fibrillation, and in fact for all arrhythmias, is what is the balance between the trigger, which initiates the arrhythmia, and the substrate, which allows it to maintain. For atrial fibrillation, we think of patients who are in that paroxysmal stage that we discussed, oftentimes have more trigger-based atrial fibrillation that causes it to initiate, but will oftentimes break on their own. Oftentimes later in the disease, as duration increases, patients will have more substrate that allows the atrial fibrillation to maintain. And that oftentimes results in a persistent stage of atrial fibrillation that ultimately might be described as permanent, depending on the clinical scenario. Now, this is important just as a rough idea of when you see a patient, whether or not they're at the persistent or the paroxysmal or the persistent or permanent stage. Because in general, and there's of course exceptions to the rule, we are better at treating triggers for atrial fibrillation or patients who are in the paroxysmal stage than we are with the substrate. We're much better earlier in the course with triggers than we are with substrate. Now, why do we care about atrial fibrillation? Well, as we all know, and it goes without saying, is that AF is associated with significant morbidity and actually mortality. Of course, patients with atrial fibrillation can be very symptomatic. Some have no symptoms, but I would say that a majority will describe at least mild symptoms associated with atrial fibrillation. Some patients don't recognize their symptoms because they creep up on them until sinus rhythm is restored and they feel better. The other morbidity that we all associate with atrial fibrillation is the cardioembolic risk. We all know that atrial fibrillation can increase the risk of a left atrial appendage, most often thrombus, that can subsequently embolize, resulting in a CVA or stroke. Finally, something that we all kind of understand but maybe don't always think about is AF patients have an increased mortality. Even if you control for risk factors like coronary disease and hypertension, there is an excess mortality associated with those with atrial fibrillation. Which is why when I first see a patient with atrial fibrillation, I oftentimes will describe it to them that this can be somewhat of a check engine light, a signal that we need to ensure that all their cardiovascular health is appropriately being managed. So clinically, how do we manage it? Well, the first priority is just what we discussed, looking at risk factors. We already went through clinical risk factors that are commonly associated with the development of atrial fibrillation. So new onset atrial fibrillation patients, we want to make sure that all of these are taken care of. One, because they could help control the atrial fibrillation, but secondly, because it might be untreated cardiovascular disease that could contribute to excess mortality. Two things that I'll highlight in this long list. One is sleep apnea. We oftentimes don't ask patients directly about sleep apnea, but over the last 10 years, we've become very aware of a very strong relationship between atrial fibrillation development and obstructive sleep apnea. Screening patients for that if they're in the right phenotype and potentially referring for a sleep study might be an important way to help treat AF patients. The second thing is weight loss. In the new 2019 American Heart Association guidelines for atrial fibrillation, weight loss has actually received a 1B recommendation. And of course, it's easy to say for overweight or obese patients to lose weight. But in the last 5 years, we've received a lot of data that shows if atrial fibrillation patients can lose weight, their symptoms and burden of the arrhythmia can really be reduced. So it isn't just another opportunity, like many in cardiovascular disease, to stress the importance of weight loss for patients. After looking at risk factors, the second priority in my mind is how do we manage the cardioembolic risk? We all understand that we can use for many patients clinical risk stratification scores to determine how high of a risk they are for a cardioembolic stroke. We used to use some simpler scores like the CHADS score. The CHADS-VAS score now is a little bit more granular in terms of telling us, especially patients who might be at a lower risk of a stroke. Now, there is no magic number that if you have above 2, above 3, you need anticoagulation. In fact, if you look at the different guidelines from Europe, from America, from Canada, they all treat this slightly differently. Obviously, the more risk you have, the more that risk outweighs any bleeding concerns associated with anticoagulation. But different point scales are probably treated a little bit different by different guidelines, and so it really has to be individualized for the patient. One thing I'll point out is that the new 2019 guidelines actually recommend NOACs, including the ones listed here, are recommended over warfarin in NOAC-eligible patients who are coming to start a new anticoagulant for AF. So while previously there was some equipoise between what got started, now the guidelines recommend a NOAC over warfarin in patients who are eligible. The other important thing to note is what's listed here is except moderate to severe mitral stenosis or mechanical heart valve patients, which is something we know. The term valvular atrial fibrillation, which we used to use, has largely been removed from the guidelines because it did leave a lot of ambiguity about patients with moderate aortic sclerosis or some other valvular heart disease. We really now just reserve warfarin to certain populations that are very well outlined in the guidelines. The only last thing I want to mention about cardioembolic risk stroke prevention is that it's a rapidly changing field. Over the last 10, 15 years, the novel oral anticoagulants have come on board, and we're still learning about their certain risks and benefits and individualizing between them for patients. There's also non-pharmacologic ways to protect patients from cardioembolic risk. The new 2019 guidelines give a 2B indication for left atrial appendage occlusion, here shown as a Watchman device, to help patients who can't tolerate anticoagulation but have a good indication for it. Keep in mind, 30 to 35% of patients with atrial fibrillation who we prescribe anticoagulation will either be intolerant or have a contraindication for anticoagulation. The third priority is the electrical management. And this is something that's a little bit complex because it is an ever-changing field, just kind of like cardioembolic risk. The two major ways to handle the arrhythmia itself is either rate control, which essentially means trying to leave atrial fibrillation in place, but just prevent their heart rate from going either too slow or too fast, or rhythm control, which essentially means trying to restore sinus rhythm. Now, intuitively, you might say rhythm control is better, but over 20, 30 years, we found out that rate control is probably just as good, if not better. And there were a number of trials listed here that actually showed us that rate control was just as good. The problem of these trials that were all done 10, 15 years ago is that the way we would rhythm control people is with the antiarrhythmic drugs. And as we all know, antiarrhythmics have poor efficacy, poor tolerability, and are relatively toxic. If you look at a large trial that showed how antiarrhythmics are used for atrial fibrillation, if you have patients giving placebo, around 90% of them will have a recurrent atrial fibrillation episode. If you give them Sodol, which is a strong antiarrhythmic, you still have around 80% having recurrent atrial fibrillation. And if you give them amiodarone, which is our best and, as we all know, relatively toxic antiarrhythmic, you still have somewhere around 60% recurring with atrial fibrillation over some time. So really what we've measured in the past and see is not rate versus rhythm control, but rate versus possibly rhythm control with drugs that have their own side effects associated with it. So the real debate between rate and rhythm control is still ongoing. We used to reserve rhythm control then for patients who failed rate control, who we just could not slow down, patients who had symptomatic atrial fibrillation where rate control was just not palatable for them. But nowadays, we're really changing what we think the indication for rhythm control might be. A couple of studies have been done that have shown that patients with heart failure or young patients might actually benefit from rhythm control. Why that? Why are we seeing that now compared to what we saw from those large trials that I mentioned on an earlier slide? Well, the reason is the way we are rhythm controlling patients now is a little different. It's with catheter ablation as opposed to antiarrhythmics alone. Catheter ablation has really revolutionized rhythm control. What do we do in a catheter ablation? Well, we observed in the late 90s that most of the triggers for atrial fibrillation, those focal drivers that we talked about before, happen to come from the pulmonary veins, where the lungs drain back into the heart, the four pulmonary veins in the left atrium. What we realize is if we electrically isolate them by essentially burning or cauterizing around the veins in two circles, we would remove the trigger, the focal driver for atrial fibrillation, and we could prevent people from having atrial fibrillation without subjugating them to an antiarrhythmic drug. And what we've seen is that this is actually a far more successful therapy than antiarrhythmics. If you look at freedom from AF with no drug therapy, no other antiarrhythmic, we have somewhere for paroxysmal patients around a 70% success rate. If you do an adjunct antiarrhythmic, you can get that upwards of 90%. So because of that, the rhythm control nowadays is very different than rhythm control in the past. You can see that we still have a difference between paroxysmal and persistent. Like I mentioned before, we're much better at the trigger stage than we are at the substrate stage. But certainly it is kind of a newly open topic on who should get rhythm control, who should get rate control, given that we're rhythm controlling differently now. Large trials that some might have heard of, like Cabana, have put a lot of answers and a lot of questions into that discussion, but it's still an area of evolution. So that's atrial fibrillation. Let's talk just quickly about its cousin, atrial flutter. Atrial flutter is essentially where atrial fibrillation organizes into one large circuit around the heart. If you look at patients with atrial flutter and have them on a telemetry and see how their atrial flutter starts, more often than not, they have atrial fibrillation and then it quickly organizes into this atrial flutter. So they really are cousins, they really are brothers, and they oftentimes are treated very similarly with regards to risk factors, with regards to anticoagulation. Now, we do make a lot of distinction between typical atrial flutter and atypical atrial flutter. And really the only meaning of that is typical atrial flutter means that the circuit involves the right atrium and specifically a piece of tissue between the tricuspid annulus and the IVC known as the CTI, the cavo-tricuspid isthmus. Every other flutter is referred to as atypical atrial flutter. Now, the reason we call this typical, the reason we try and discern this is because in the electrophysiology lab, typical atrial flutter is relatively easy for us to treat. We can burn that little isthmus between the IVC and the tricuspid annulus and get rid of typical atrial flutter relatively easy. Atypical atrial flutter is a lot more challenging and much more akin to atrial fibrillation or persistent atrial fibrillation. The reason that we care about this is because for some patients, atrial flutter has a very different symptom profile than atrial fibrillation, but they are related. If you do an atrial flutter ablation alone, just get rid of that isthmus, around 60 to 70% of patients will come back with atrial fibrillation in the next 2 years. Moving on from atrial fibrillation, there are some regular paroxysmal SVTs that we wanted to spend just a couple minutes on. If we look at the epidemiology, the vast majority of these now regular, not irregular, but regular SVTs are AVNRT, around 65%. Around 30% will be ORT or atrioventricular reentrant tachycardia or orthodromic reentrant tachycardia, or another term is Wolff-Parkinson-White or accessory pathway-mediated tachycardia. A lot of synonyms essentially means that the path of the arrhythmia includes an accessory pathway. There's also a small minority of patients that have atrial tachycardia as their mechanism. What is atrial tachycardia? Just briefly, it's like atrial flutter, where the atrium is kind of doing its own thing, but as opposed to being a large circuit, there's one focus. The focus could be because of triggered activity within a myocyte, which is oftentimes calcium-related, automaticity within a myocyte, or even just a small circuit. Sinus tachycardia is something we get called for a lot, inappropriate or physiologic, which if you think about it is just a form of atrial tachycardia. Multifocal atrial tachycardia is also very common, where multiple different foci are firing at the same time, kind of competing with each other. And as you can imagine, some of these patients actually are pre-atrial fibrillation. If you look at here, where are the sites of origin for atrial tachycardia, a lot of them are in the pulmonary veins, which for many people can ultimately lead to atrial fibrillation. Now, AVNRT, or atrioventricular nodal reentrant tachycardia, essentially happens when young, healthy patients, oftentimes, will have an AV node that can somehow get a electrical impulse to go both down as well as up. We define this as having both a slow and a fast pathway, which around 30% of people do. If that's the case, then certain conditions, we can get kind of a rapid reentrant circuit to occur within the AV node itself. Management for this is variable. Young, healthy patients don't often tolerate beta blockers or calcium channel blockers. In the electrophysiology lab, we can remove or burn away, cauterize, or freeze the slow pathway to leave you with one healthy, fast pathway. It is oftentimes a very highly sought after treatment for symptomatic patients with AVNRT. The last thing is AVRT or ORT or Wolff-Parkinson-White, essentially a reentrant circuit involving an accessory pathway. There can be orthodromic reentrant tachycardia, where it goes down the AV node and up the accessory pathway, or antidromic, where it goes down the accessory pathway, up the AV node. Some people say the patients cannot have AVRT unless you see pre-excitation on their EKG, but that's not necessarily true. Manifest pre-excitation occurs when you can see the pathway going down from the atrium to the ventricle. But most pathways are actually what we call concealed, where they only are one-way streets going up from the ventricle to the atrium. The management of this depends on two things. One is the symptoms of the patient. Some patients are very asymptomatic. Some patients have a lot of symptoms. And the second is what we stratify the risk of this accessory pathway to be. As we know, there are some patients with an accessory pathway that, if they had atrial fibrillation, could unfortunately have rapid conduction down the pathway and have atrial fibrillation. So to summarize, atrial fibrillation is the most common arrhythmia and associated with morbidity and mortality. It is the most common SVT, so common that we often put it in its own bucket. Management decisions, including risk factor management, specifically sleep apnea and weight loss, are things that we oftentimes really focus on. Management of anticoagulation or other non-pharmacologic ways to prevent cardioembolic risk. And then rhythm management, which might include rate or rhythm control, and that's a discussion that's evolving. Paroxysmal regular SVTs, including AVNRT, AT, and AVRT, are often symptomatic, yet less commonly associated with mortality, such as cardioembolism, as compared to atrial fibrillation. I have a minute left here, so I thought we could go through a couple of quick questions. This one is pertaining for a 70-year-old woman with diabetes and rheumatic mitral stenosis who's coming in with dyspnea and fatigue. She has atrial fibrillation and has had that in the past as well. She has hypertension. She has mild left ventricular dysfunction related to coronary artery disease and a prior MI. Her medications include atenolol, lisinopril, aspirin, atorvastatin, and insulin. She has an irregular rhythm with a heart rate of 78 beats per minute. Blood pressure is normal, and her cardiovascular and pulmonary exams are always unremarkable. What medication should this patient receive for at least 3 to 4 weeks before cardioversion? So I know people are still voting, but what I'll just quickly go to the answers, we're running out of time, is warfarin is the answer here. So while we did discuss the new guidelines actually recommend a NOAC like rivaroxaban over warfarin, keep in mind there are certain exceptions to that rule, and rheumatic mitral stenosis is one of them. Dual antiplatelet therapy with aspirin Plavix is inferior to warfarin, so would not be the right answer here. And I think I'll stop there. Thank you very much for your time and attention.
Thanks, Sunil. That's great. I'm going to work through a few questions with you, if you'd allow me to do just a moderated Q&A. So there are a couple of questions about monitoring of patients, one of which is, the issue of these newer devices like using the CardiaCare or the Zeo device and comparing that to the or the Apple Watch and comparing that to perhaps other more conventional things like Holter. What's your recommendation around that? What are your thoughts on that?
Yeah, I think that's a great question and something that's actively evolving. We don't have a great consensus of one device is better than the other. In general, many of these devices do give relatively high fidelity signals. That's not always the case, but the medical grade Holters and Zeo patches and so on and so forth that we use oftentimes are comparable signal quality to what we get from some of these other kind of direct-to-consumer devices. So we can't really use the cop-out, well, these are not good enough. In terms of how we monitor patients, it's difficult. We do know that it really depends on the pretest probability in terms of how likely you think someone is. If they're having intermittent palpitations, if they say, I have it, and they can use their watch, use their home smartphone to capture those events, those can be pretty reliable and very helpful. I will say that there are a number of patients, though, that we unfortunately turn into nervous Nellies about constantly checking their heart rate and their rhythm and whatnot. And so there is a balance. We don't have a great consensus, but I think it's something that we're definitely going to deal with more. And I think we'd be wise to try and incorporate that into how we manage patients with these paroxysmal arrhythmias.
Also, second question. There's this discussion about higher birth weight was associated with an increased risk of atrial fibrillation during adulthood. And it does seem like in some studies that where they've adjusted for various covariates that the risk is quite significant. Can you speak to that a little bit? What do you know about it? And should people ask about this?
Yeah, there are numerous risk factors associated with atrial fibrillation, and how each of them play in different populations is somewhat unclear. We really spend a lot of time on that list focusing on the modifiable risk factors, but we know, for example, genetics and birth weight, and a lot of these things do play kind of a hand that we can't really treat. We're not yet at a stage where we can use the granular phenotype of patients saying this gene, this birth weight, this whatever would impact what treatment strategy we would want. We're not at a stage where we can use kind of a precision medicine or personalized medicine where this profile, we know you do better with this ablation or this sotalol or whatnot. Hopefully in the future we'll get there, but all of these risk factors are things that we try and, the ones that we can modify, work through to see if there's some way to kind of impact their clinical course.
Great. And then last question, and I know there are a number of other questions. I'll try to get to them when I have the Q&A with Usha, but a quick one here. What proportion of patients that undergo catheter ablation will require a pacemaker due to symptomatic bradycardia? And then just relatedly, I know post-ablation anticoagulation is also something that some people wonder about. So could you just discuss the post-ablation scenarios very briefly?
Yeah, sure. So, it's an evolving area, but in terms of the anticoagulation, we're not yet at a stage where ablation is good enough or has enough long-term data that we can definitively say that even if you have an ablation and you no longer have atrial fibrillation, your cardioembolic risk goes down to 0. So even if you never have atrial fibrillation again, you still had atrial fibrillation in the past, you still had a CHADS VAS score of whatever it may be, we're not yet at a stage where we would say we can stop the anticoagulation. In fact, for 3 months after an ablation, because we oftentimes cauterize or freeze the endocardium of the left atrium, they're at a higher risk. So we almost always are very aggressive at anticoagulation, especially in those first 3 months. Maybe data will change in terms of our ability to say, well, we quote unquote cured your atrial fibrillation, you no longer need the anticoagulant, but that's not the data as of today. In terms of a pacemaker, it's very, very uncommon to have a complication of the ablation be a need for a pacemaker. We fortunately or unfortunately do most of our work far away from the sinus node and far away from the atrioventricular node, and so that would be uncommon. Certainly, though, the same risk factors that lead to cardiac conduction system disease, the same risk factors that lead to sinus node dysfunction cause patients to have atrial fibrillation. So there are many patients who we get rid of the atrial fibrillation, but whatever caused their atrial fibrillation also caused sinus node dysfunction. And those patients will occasionally need a pacemaker. But certainly it's almost two separate yet related issues, and one doesn't necessarily need to lead to the other.
Great, thank you. And I just want to say thank you for a wonderful discussion and presentation. And we're going to move on to the next talk. Thanks again.
My pleasure. Thank you.